My name is Bill Dubbs, and I am the AARC Director of Education and Management Services. I welcome you to today's webcast on theories of ethical decision-making in respiratory therapy. The AARC is committed to providing you with current information on topics of interest through the convenience of webcasting, and we thank you for participating. Upon completion of this AARC webcast, participants will be able to differentiate between breaches of law and breaches of ethics, resolve to safeguard patient privacy, embrace the importance of the assurance of ongoing competency, list 3 elements implicit in a fraud case, and differentiate between a living will and a durable power of attorney as instruments of advanced directive. I'm pleased to introduce John Hughes. John is a registered respiratory therapist and a certified asthma educator. He's a member of the AARC's Ad Hoc Committee on Ethics and has served for many years as program director at Millersville University Program in Respiratory Therapy at Millersville, Pennsylvania. John, welcome to the program.
Hi, Bill. Thanks for inviting me.
We're delighted to have you. John, as we begin the program today, there are many folks that don't really understand the difference between what's illegal and what's unethical. Can you address that topic for us?
Sure, thanks. I'll be glad to. I'd like to do so in the context of a challenging situation. That's reporting an illegal act. In an ideal world, we would hope that this topic would never need to be addressed in a discussion on professional ethics. But the truth is that most of us find ourselves in a dilemma if we become aware of an illegal or unethical practice. We get hung up on our duty to report the act and our loyalty to a coworker. Review boards from all professions, including ours, have encountered practitioners who have engaged in illegal and in unethical acts resulting in professional sanctions. So let's get to the definition. Merriam-Webster's Dictionary of Law, we find the illegal defined as simply contrary to or in violation of a law. That's really simple. Ethics, on the other hand, is defined as pertaining to or dealing with morals or the principles of morality, pertaining to right and wrong in conduct, and also being in accordance with the rules or standards for right conduct or practice, especially the standards of a profession. So there seems to be a somewhat softer definition regarding behavior when it comes to ethics. The lines seem to be more or less blurred and discretionary rather than clean-cut as they are in strict law. So let's get back to what our responsibility is if we become aware of an unlawful or unethical act. Well, respiratory therapists are entrusted to provide quality care under the supervision of licensed physicians, and we're required to practice within the boundaries of our scope of practice. Respiratory therapists must refuse to engage in illegal and unethical acts. Furthermore, we have the ethical responsibility to refuse to abet or conceal the negligent, fraudulent, or illegal acts of others. Criminal or civil charges and professional sanctions may result if we fail to do so. So it's clear that there are legal consequences if you're found to have broken the law, but how about ethics? In the same way, we are obligated to report breaches in ethics. Let's have a look at an example. Not too long ago, a high-profile case on the West Coast, a respiratory therapist who was dubbed the Angel of Death, allegedly confessed to the mercy killings of over 50 terminally ill patients by injecting them with Pavilon. Well, after a lengthy investigation, he was convicted of the murders of 6 patients and attempting the murder of a 7th. The respiratory therapist who committed these acts is currently serving 6 consecutive life sentences for those murders. In 2002, the co-worker who testified that she supplied Pavilon to the Angel of Death was ordered to pay $10,000 for reimbursement of prosecution and investigation costs, and she had her license to practice respiratory therapy revoked. In addition, 3 other respiratory therapists who were granted criminal immunity in exchange for their testimony in the case. But they were also found they're accused of negligence, incompetence, and unprofessional conduct. Furthermore, these 3 received professional sanctions for their failure to report what they knew or suspected of their coworker, and their licenses currently remain on probation. Well, this case clearly demonstrates that respiratory therapists must refuse to participate in or cover up the illegal or unethical acts of others. Therefore, when suspicions arise, it's the ethical obligation of the respiratory therapist to report concerns to an immediate supervisor. The angel of death committed multiple acts of premeditated murder on numerous patients entrusted to his care. The respiratory therapist that supplied the drugs was an active accomplice in the deaths of those patients. She was legally culpable in this case. Through their silence, the respiratory therapists who neglected to report their suspicions of the angel's activities assumed a passive role in the deaths of those patients and endangered the lives of other patients. So although not directly culpable, they are ethically responsible to report the illegal activity. Professional sanctions were levied against each of these individuals. So what would you do if you overhear a conversation between two of your colleagues? They're discussing how they expedited the demise of a terminally ill patient. What action, if any, should you take? Ignore it? We'll call hospital security? Report your concerns to an immediate supervisor? Or leave a copy of the AARC Code of Ethics in their mailboxes? Well, the only one that's correct here is to report it to your immediate supervisor. You know, you could call hospital security and have their lockers gone through, but that's probably premature in this case, and it would cause trouble if it ended up not to be the case. Leaving a copy of the Code of Ethics in their mailbox would probably miss the point, but might be a good idea. So anyway, that's that one. Let's move on now to patient confidentiality. We have a lot of ground to cover here. Our concepts about patient confidentiality come from a patient's right to privacy. You know, many of us need access to the medical information of hospitalized patients in order to provide their care. However, patients have a right to expect that their information will be kept confidential and will only be made available to those who have a need to know. Both federal and state statutes protect the confidentiality of patient information. The recent Health Insurance Portability and Accountability Act has many rules concerning the use of and disclosure of patients' health information. And as a respiratory therapist, it's your legal and ethical duty to maintain patient confidentiality. HIPAA has taken patient confidentiality from the realm of ethics and now has made it a legal issue because it's now under law. Well, in general, patients must consent to have their medical information shared with a third-party payer, such as an insurance company or an employer. But if you're caring for patients, you may discuss their information with another healthcare worker as necessary, but information should not be disclosed to anyone who's not taking part in that patient's care. There are some situations where confidential information may be disclosed without the patient's consent. One situation would be when the interests of society or another individual outweigh the patient's right to privacy. For instance, we are required to report child abuse to the authorities, even if doing so would breach patient confidentiality. Or we might be required to report a case of active TB to the health department, even if the patient requests that we don't do that. Well, as a respiratory therapist, you need to consider the consequences if you breach patient confidentiality. The effect of unauthorized disclosure would be emotionally or possibly financially devastating to a patient. Although all information is confidential, some information is especially sensitive. Psychiatric information or information concerning sexual activities would almost surely cause emotional distress if made public. And disclosure about substance abuse or genetic disorders might affect that person's employment prospects. If you, as a respiratory therapist, make an unauthorized disclosure, you may suffer serious consequences such as dismissal from your job, loss of your license, and even civil action from a patient that you harmed. Let's look at a case. If you're caring for a 24-year-old patient who was an MVA 2 days ago. He's currently on a ventilator on volume control, but he's developing ARDS and is becoming very difficult to ventilate him. So you would like to switch him to an oscillator, but you haven't been able to get in touch with Dr. Damsel, his physician, in order to get the order changed. While you're on the elevator, Dr. Damsel gets on. You tell her you have been trying to get in touch with her for the past hour, and she apologizes and says she's been busy running from one crisis to another. And then she asks you what you need. Although there are a couple of visitors in the elevator with you, you haven't seen them in the ICU waiting room, and you're pretty sure they aren't here to visit your patient. But noticing Dr. Damsel's impatience, you go ahead and you tell her the situation. But you're careful not to say the patient's name. You only refer to him as the 24-year-old MVA in ICU. Well, she gives you a verbal order to switch to the oscillator and then rushes off the elevator. Well, here's a situation where you have to weigh the urgency of a patient's medical needs against his confidentiality rights. However, this doesn't usually need to be an either or situation. You can usually find a way to accommodate both. So in this scenario, was the patient's confidentiality breached? Well, the visitors on the elevator had no right to hear about your patient's condition or treatment, and your assumption that they didn't know the patient misses the point. The fact of the matter is that you had no authority to disclose your patient's health information to anyone who was not involved in his care. You have violated your patient's right to privacy. Referring to your patient as the 24-year-old MVA in ICU provided enough information to allow someone to identify your patient by name. In fact, your information was specific enough that Dr. Namsel immediately recognized the case. So if by chance you were incorrect in your assumption that the visitors didn't know your patient, they would almost certainly know that you were referring to him and might have been emotionally devastated to learn that his condition was worsening. So, what would have been the best way for you to handle this situation? I believe the best thing for you to have done would have been to get off the elevator with Dr. Damsel and go to an area where you couldn't be overheard before discussing that patient. Is it ever acceptable to discuss your patient in an elevator? Well, the answer to that is if only you and Dr. Damsel are in the elevator, it would be acceptable. However, if the door opens and other people get on, then you need to curtail that conversation. Well, what would happen if you ended? What would happen to you if the visitors on the elevator complained that you were discussing a patient in their presence? Well, you could face disciplinary action by your hospital. Charges could be filed with your licensing board. And the patient could sue you for disclosing his confidential information. So it's pretty serious. Okay. Let's move on now to conflict of interest. Generally speaking, a conflict of interest occurs whenever a person has an obligation to perform a duty to one person or entity and simultaneously has an obligation to a second person or entity, which is or may be in opposition to the duty that's owed to the first. Suppose that you're a silent partner in a home care durable medical equipment company, and you have financial interest in the company. You're not involved in the day-to-day running of the company, but the company sells or rents a wide variety of medical equipment, including home oxygen systems. Your full-time job is at the Metropolitan Medical Center as a respiratory therapist. But you're asked and you agree to serve on the respiratory care department as the respiratory care department's representative on Home Health Coordination Committee. Well, this committee coordinates the hospital to home transition of patients who have home care needs. Well, at the very first committee meeting, you notice that you attend the committee, and the committee chair announces that the hospital is writing a new policy for referrals to home health agencies, such as the one that you are part owner in. The committee chair asks you to be in charge of the policy subcommittee. Can you see the conflict? Well, you remember that whenever a conflict of interest exists, whenever a person is called upon to fulfill a duty to two or more persons, when the persons to be served may have opposing interests. Well, it's pretty clear that if you serve on that subcommittee, you will have a conflict. First of all, you have a fiduciary duty to your company to help it succeed, and a personal financial interest, meaning you will benefit monetarily if your company succeeds. Well, clearly, the more business you could direct to your company, the better it would be for you. On the other hand, you have an ethical obligation to your patients to assure that they get a fair recommendation of a home health service that provides adequate and appropriate services at a competitive price. In this situation, even if your home health company provides the best service at the best price, if the policy you write in any way favors your company, you could be accused of having a conflict of interest. Regardless of the action you take on the subcommittee, the appearance of conflict will be overwhelming. One of the key points to remember here is that even if all dealings are fair and neither your business or you benefit from your position on the subcommittee, the conflict still exists. Anytime you have the power to influence the action of one party to whom you owe a duty, in a circumstance where either you or another party to whom you are obligated may benefit, a conflict of interest exists. So which of these following statements is true? You have a conflict of interest as a leader of the subcommittee because you or your company may benefit from the home health referral policy that you write. Number 2, you have a conflict of interest as a leader of the subcommittee because you owe a duty of fairness to your patients. And 3, you have a conflict of interest as a leader of the subcommittee even if you take no action that benefits your company. Well, frankly, all 3 of these are true. Presuming your subcommittee develops a policy that rotates the referral of patients to all the home care companies in the area, are the statements still true? Yes. Yes. Even though your home care company will not have an advantage over the other home care companies, the appearance of a conflict of interest still exists. So it's a little more than you'd think. Okay, let's address continuing competency, the next topic. You know, the need for lifelong learning and continuing competency documentation is an extremely important issue in medical ethics. The healthcare environment changes continually as a result of advancements. And consequently, the necessary knowledge and skills that are expected in a new graduate are evaluated using a continually evolving licensure examination that assesses readiness to practice. The one-time documentation of entry-level skills is not sufficient to ensure that the practitioner remains competent after the passage of a couple of years. This is especially true where the practitioner moves from one specialty practice to another, for example, leaving acute care and going into home care, or from pulmonary function lab into a critical care position, or even just more subtle changes. Consequently, the concept of lifelong learning must be introduced to students during the education programs as a lifelong professional lifestyle. Mandatory continuing education requirements as specified by credentialing bodies like the NBRC and various state licensing boards promote ongoing learning. And congratulations, that's what you're doing right now. In December 1995, the Pew Health Professions Committee issued its now landmark report, Reforming Healthcare Workforce Regulation, Policy Considerations for the 21st Century. I think we need to move down to another slide here. There we go. This policy called for national consistency in the entry-level practice standards for healthcare workers. The document also called on the states to require each board to develop, implement, and evaluate continuing competency requirements to assure that continuing competency of regulated health care professionals was in place. The underlying foundation for the proposed changes was to assure public safety as the healthcare environment evolves. Well, widespread discussion began as a result of the Pew report, but it appears that in 2003, the Institute of Medicine issued a report entitled Health Professions Education: A Bridge to Quality. Well, this one called for all licensed healthcare professionals to demonstrate their continuing competency to deliver patient care. The IOM went further and defined 5 core competencies necessary for competent practitioners. Here's what they are. The 5 core competencies included providing patient-centered care, delivered by members of an interdisciplinary team, and based on evidence-based practices, using quality improvement approaches, and using information technology. Patient safety and the ability to provide quality care depend on having a healthcare workforce that's not only competent at entry into practice, but also maintains competency throughout the professional career. Consumers of healthcare, including patients and their families, have a right to expect that the caregiver is competent to practice within the professional scope of practice as it evolves. Let's take a look at a scenario here. Mary recently returned to work as a night shift therapist following her maternity leave. During her absence, the department added inhaled nitric oxide therapy to its scope of services. At 3 a.m., a patient with sepsis and pulmonary artery hypertension is transferred to the SICU from an outlying hospital. The physician requests a trial of INO therapy. Well, Mary has read the policy and a procedure for INO therapy and has reviewed the equipment set up with the shift supervisor. She has not, however, completed the department's orientation activity, which includes being signed off on her ability to prepare the INO vent and initiate therapy and monitor the outcome. So Mary pages the shift supervisor. However, the supervisor is tied up in the ED. The supervisor tells Mary that he will not be able to leave the ED and give her assistance for at least another 30 minutes. Well, Mary has the policy and procedure manual readily available there in the SICU, so she tells the supervisor that she feels confident that she can start the therapy since the INO vent is all set up and ready to use. The principle of beneficence applies in this scenario. Beneficence is action that is done for the benefit of others. Beneficent actions can be taken to help prevent or remove potential harm or to simply improve the situation of others. As a licensed respiratory therapist, Mary has an obligation not only to provide good care, but to also refrain from engaging in any care activities that may result in patient harm. The principle of non-malbeneficence applies here. Non-maleficence, rather, means to do no harm. RT's got to refrain from providing ineffective treatments or acting with malice toward patients. That's basically what that says. So Mary has to introduce must introduce the nitric oxide delivery system into the circuit of a conventional mechanical ventilator. There's another number of steps that must be performed in order to deliver nitric oxide safely. So while assuring that the conventional mechanical ventilator is continuing to function properly. So this comes into an issue of role fidelity. Now, role fidelity, that relates to one's duty to practice at a standard of competence. And this is a key concern in this scenario. So while administering inhaled nitric oxide is clearly within the scope of practice and the scope of services for this department, Mary, as an individual therapist, has not completed the activities that demonstrate her competency in delivering that mode of therapy. Consequently, if Mary chooses to implement the therapy, she will breach the limits of her role and thus potentially place the patient in harm's way while potentially exposing the institution to legal liability. So when she receives the order to initiate the inhaled nitric oxide therapy, what should she tell the physician? Well, patient does not qualify for nitric oxide therapy. That's A. B is, I have not been oriented to this procedure, but I will call my supervisor for assistance. C. Okay, but it'll take me a few minutes to get everything ready. And D. I'll be busy getting the regular ventilator ready, but I'll call someone from another unit to set up the nitric oxide. Well, the first one, the patient doesn't qualify for nitric oxide, is obviously incorrect. This isn't even true. The second one is the correct answer. Acknowledging that she has not been oriented to the procedure and asking for help from the supervisor is appropriate. This action signifies to the ordering physician that the order has been acknowledged and that action to implement the order has been taken. The other two are not correct either. So B is the best pick there. Next question is, which of the following best describes appropriate actions for Mary to take following her discussion with the shift supervisor? Well, let's look at these four. Seek assistance from a respiratory therapist that's assigned to another intensive care unit. 2, bring the inovent to the patient's room and position it by the bed. 3, obtain baseline physiologic parameters needed prior to implementing the nitric oxide therapy. And 4, initiate the inhaled nitric oxide therapy as ordered. So which do you think are correct? Well, 2 and 3 are correct. Obtaining the equipment needed to implement the requested therapy and placing it in the patient's room is an appropriate preparatory action. Also, baseline physiologic parameters needed prior to implementing nitric oxide therapy are needed, since they're going to be used as the basis for evaluation of the effectiveness of the therapy once it's been started. So this is an appropriate preparatory action. Okay, on to discrimination. Discrimination is defined in Webster's New World Dictionary as a showing of partiality or prejudice in treatment, specific actions or policies directed against the welfare of minority groups. And minority groups are defined as racial, religious, ethnic, or political groups smaller than or differing from the larger controlling group in a community, nation, etc. Well, American society has advanced the consideration of minority groups to include gender, creed, race, religion, disability status, national or ethnic origin, age, and in some cases, other identifiable characteristics. So discrimination is also known as bias or prejudice, and it's broadly perceived as suspicion, intolerance, or an irrational hatred for people who are different from the majority. In regard to the provision of healthcare, discrimination is manifested as disparity, and that would be the unequal quality or amount of diagnostic or therapeutic care. This may be seen in a situation where a therapist gives first attention to a patient of his own race and neglects to attend to an equally needy patient of another race. Age discrimination has become a high-profile issue in recent times. Usually, the bias of the offending professional is against the older patient. Younger therapists may not understand senior citizens, or the therapist may feel that the senior citizen no longer has a productive or useful use in society. So prejudice against senior citizens can lead to substandard care and negative consequences for that senior. Discrimination serves as a confounding filter that leads that healthcare professional away from the focused needs of an individual patient. So it's the distraction. So when such prejudices are in place, it compromises a therapist's ability to properly triage and allocate care. So for this reason, it's imperative that the principle be carefully inculcated as a part of every respiratory therapy program curriculum. The concept of equal treatment in a medical context usually predates the Constitution of the United States. Equal care of patients is stated or implied in most all documents and codes of medical ethics, extending way back to the Hippocratic Oath. And the United States Department of Health and Human Services lists 7 rights in the patient's Bill of Rights. The 5th one reads like this. It says, care without discrimination. Patients have the right to considerate, respectful care from all members of the healthcare industry at all times and under all circumstances. Patients must not be discriminated against in the marketing or enrollment or in the provision of healthcare services consistent with the benefits covered in their policy or as required by law based on race, ethnicity, national origin, religion, sex, age, current or anticipated medical or physical disability, sexual orientation, genetic information, or source of payment. Pretty comprehensive. Let's have a situation to look at here. Got a newly graduated respiratory therapist. He's assigned to draw an ABG in an isolation room on an infectious disease floor in a community hospital. Well, the therapist reviews the rather thin chart of a newly admitted patient suffering from dramatic weight loss, sores in his mouth, and some form of pneumonitis. The etiology is currently unknown. It appears that he's homeless and he's been living outside of town in a van, and It's also reported to have a long history of IV drug abuse. The therapist, without even entering the patient's room, called down to the department and told the supervisor that he would not do the stick because he feared becoming infected. Well, while it's appropriate to carefully regard an infectious threat like this, the therapist should not be in danger of exposure, provided he practices universal precautions as he was taught in school and is mandated by the hospital. The therapist may not discriminate against the patient based on lifestyle or pending diagnosis. Even if the patient is diagnosed with TB or HIV/AIDS, the therapist is obligated by the hospital employment contract to render care without discrimination. Further, the ethics principles of beneficence and role fidelity mandate that the health professional offer beneficial care to patients in need according to their codes of conduct and professional education and scope of practice. So what options does this therapist have with regard to caring for or not caring for this patient? Well, he can ask the supervisor to have somebody else do the stick, but if staffing requires that he does it, the puncture himself, then, like it or not, he has to do the puncture. Here's another question. Even if the supervisor insists that the therapist perform the arterial stick, the therapist refuses to do the procedure, what should that supervisor do now? Well, the department might consider temporarily suspending that individual or even terminating him. Number 3, after a counseling session with the therapist, the hospital officials decide that the therapist received an inadequate education in his respiratory therapy program regarding infectious disease and prophylaxis. So now what should the hospital do about this admission? Well, if the therapist is well qualified in all other aspects of clinical performance, the department may choose to habilitate his infectious disease management phobias by taking the young man off the work schedule and having one of the supervisors educate him about the self-protective safety precautions and infectious disease that he needs to learn. Alrighty, let's move on to fraud. Fraud in medical practice. The term fraud is generally defined as an intentional perversion of truth for the purpose of inducing another in reliance upon it to part with some valuable thing belonging to him or to surrender a legal right. Put another way, it's making a false representation by words, conduct, or concealment of a fact that should have been disclosed, which deceives and is intended to deceive another person so that the other person acts upon it to his detriment. Because fraud is an intentional act, which is devious in nature and generally considered to be harmful to society as a whole, we treat fraudulent acts rather harshly. There's literally hundreds of state and federal laws and statutes which define and prescribe and punish fraudulent acts. Well, as a licensed respiratory therapist, the commission of a fraudulent act may result in the loss of your license to practice, not to mention potential criminal penalties, civil liabilities. There's 3 basic elements to fraud. To prove fraud, all 3 elements must be proven. First, you have to have knowingly made a false representation of a present or a past fact. Fraud is an intentional act. And therefore, when you misrepresent something, you must know that you're doing it. So a simple mistake is not fraud. The second element is reliance upon the deception by the person complaining of the fraud. This means that the person whom you deceived must believe the deception. The third element is damage to the complaining party caused by the misrepresentation or deceptive act. The key here is that the intentional deceptive act, which was relied upon by someone else, must be directly linked to some sort of damages. Another way of saying this is that there must be a causal connection between the act and the damages suffered. So if you tell me a lie, I believe it and I act upon it, but I'm not harmed in any way, a fraud claim against you fails. Let's take a look at a scenario. Say you're employed as a staff therapist in a large medical center. So on a Friday evening, several therapists call in sick, and as a result, you're assigned to a very heavy load of work. Midway through your shift, you have kept up with the work, but a code blue is called on your floor, and after participating in the code, you find out that you're behind, and you know you can't complete the work. So you call your supervisor for help and tell her that it will be impossible for you to complete the therapy load. Well, she tells you that no help's available, and she reminds you that the department's revenue figures for the year have been down. Suggests that you do your best to complete all of your assignment, and while again mentioning the declining department revenues, she encourages you to make sure that you complete your billing documentation. While you triage your patients, make sure that those who are in the need of most care are treated first, but at the end of your shift, there comes along and there's 4 elderly but stable patients whom you didn't see at all. So with your supervisor's revenue statements in mind, you chart that you administered the treatments ordered on the 4 elderly patients. Your supervisor congratulates you on a good night's work and enters all your documented treatments into the billing system. The 4 elderly patients are billed for the missed treatments. Well, was there an attempt to commit fraud? Well, in the scenario, you clearly satisfy the first element of fraud when you falsely charted that you completed treatments that you didn't give. Well, was there reliance upon the false charting? That's item 2. While the patients may have known that you didn't provide their treatments, they didn't know that you charted that you gave them, and they probably didn't realize that their bill included the missed treatments. So fraud element 2 is satisfied. The elderly patients paid the bill for the therapy they didn't receive, and they were thereby damaged. Thus, all 3 elements necessary to convict you of fraud are provable. It doesn't matter that you didn't personally submit the bill, or that you may not even have personally gained from the fraudulent act. Your respiratory therapy license is in jeopardy of suspension or revocation if you're convicted of a crime. And fraud is a crime. It's a crime involving moral turpitude, and thus may be found to be substantially related to your qualifications to provide health care at all. So why might you be found guilty of fraud even if you didn't profit from the deception? Well, profit on the part of the person committing fraud is not a necessary element of the crime. So it doesn't matter that you didn't profit. What would have been your best course of action after you spoke with your supervisor? Well, at the end of your shift, you should have documented that you're unable to complete the ordered therapy on the 4 elderly patients. Or you might have respectfully asked your supervisor to clarify how she wants you to handle that situation. You should always document missed therapy. And after all, you may have just misunderstood the supervisor. All right, let's finish up with an overview of informed consent and advanced directives. The question of consent goes to the matter of trespass against the person. In common law, it's considered battery to interfere with a person without your consent. A battery claim may result when a clinician either exceeds the scope of what was consented to or performs a different procedure than the one for which the consent was given. Most informed consent cases aren't prosecuted under battery law, though. They're rightly tied under negligence law. So the doctrine of informed consent is centered on several realities. Number 1 is that people desire to have control over medical measures they submit themselves to. They have the right to accept or refuse any medical procedure. Secondly, decisions regarding medical treatment often carry life-changing consequences. Patients and or their surrogates have a right to full disclosure of the potential for the desired outcome to be realized and the hazards / complications inherent in that procedure. 3, patients and their surrogates often lack the knowledge to fully understand the risk-benefit profile of medical treatment, so it's incumbent upon the clinician to accurately and articulately present it. Well, the essence of informed consent law dictates that certain elements must be disclosed to the decision maker. These include a thorough disclosure of the nature and purpose and expected outcomes of a procedure. Has to be a presentation of the risks and consequences that are inherent in the treatment and the frequency with which they may be expected to result. Also, there needs to be an overview of the alternative choices that may exist and the consequences of those choices. Also, a realistic projection of what will result if the decision maker refuses the procedure or treatment. So those four elements ought to always be there. Whose responsibility is this? Well, it's the obligation to obtain informed consent is the physician's responsibility. Respiratory therapists are not to take it upon themselves to explain the risks or benefits of a procedure to a patient or to surrogates. All procedures don't require consent. It's generally not necessary to obtain informed consent for minor low-risk procedures that are carried out as a part of regular medical care. These would include blood draws and positioning, suctioning, simple bedside diagnostic tests, things like that. Consent might also be circumvented in an emergency or in a case where delaying the treatment would result in significant harm to a patient. Consent may be express or implied. Patients can agree to treatment in a number of ways. They can give verbal or written, which is express consent, or consent may be implied by the circumstances. Consent for general nursing and respiratory care is usually implied by virtue of the patient being admitted to the hospital or the service. Implied consent has also been assumed in cases where the patient is unconscious or otherwise unable to give consent. Treatment can be initiated on the basis of that patient on the basis that that patient would have expected to give consent, knowing that this is what good medical practice demands. So what's our role in this? As respiratory therapists, we practice under medical direction. We're rarely called upon to obtain this consent. The RT must, however, be aware of what was discussed with the patient with regard to the treatment and not perform a procedure that falls outside the scope of that for which consent was given. The RT may also be called upon to serve as a witness when the patient signs the form. Another form of express consent is might be put in place by drafting one of several legal documents in advance to the need for medical decisions to be made. These vary from state to state, but generally they fall into several following categories. Durable power of attorney, or a POA. This document allows a patient to legally appoint another adult to make decisions about his or her health care. If he or she were to become unable to make decisions for herself. The surrogate then is expected to act according to the patient's wishes. In some states, if a document doesn't exist, a spouse, parents, adult siblings, and adult children may make these decisions. But because of all these people will have the same authority, it's best to appoint one person to decide in the event of disagreements. So having a durable power of attorney takes the touchiness out of end-of-life decisions when several different members of a family might be jousting over what's best. Living will is another document. If a patient becomes terminally ill and is expected to die within a short period of time, this completed form will direct a physician regarding the administration of treatment and will also limit the extent of life-sustaining measures. This is a method of informing medical practitioners regarding your wishes in the event of a terminal illness. It's not a legally binding document. A living will should address several things. One is artificial nutrition and hydration. A variety of therapies meant to prevent dehydration or malnutrition in a patient who can't reliably swallow. And most commonly this involves IV therapy and total parenteral nutrition, nasogastric tube feedings, or feeding tubes, J-tubes. So a terminally ill patient may opt not to have these. Also, DNR is another, though I'm sure we're all familiar with. Do not resuscitation order, just another form of advanced directive. And a DNR is a request not to have cardiopulmonary resuscitation in event of a cardiac arrest. A DNR order is placed in a medical chart by the attending physician. The DNR orders are accepted by physicians and hospitals in all of our states. A family member or close friend can consent to a DNR order only when the patient is unable to decide for him or herself and has not appointed someone as a surrogate decision maker. A family member or friend can consent to a DNR order in these conditions if the patient is terminally ill or permanently unconscious, or if CPR would be medically futile, or if CPR would impose an extraordinary burden on the client given his or her medical condition and expected outcomes of CPR. So anyone making a DNR decision must base that decision on the client's wishes, including religious and moral beliefs. If his or her wishes are not known, on the client's best interest, those decisions will be made. Okay, let's wrap this up with do not intubate. Do not intubate order. It's a declaration that may be recorded in a living will specifying conditions under which a patient wishes to have this withheld. This may also include a do not ventilate directive, which also may rule out the use of non-invasive positive pressure ventilation. The use of NPPV in terminally ill patients who do not want to be intubated and mechanically ventilated is currently controversial. Some caregivers consider this practice inappropriate, arguing that it's essentially giving life support to patients who don't desire it. Others insist that NIPPV is helpful for dying patients who have rejected intubation because it can alleviate respiratory distress and offer them time to put their affairs in order. So this is currently something that's being, you'll be seeing this coming on the radar screen. A living will may also include specific healthcare directives, including tissue donation and comfort care. Sort of on the other end of things, patients might also opt for a life-prolonging procedures declaration. This document permits a patient to request the use of life-prolonging procedures that would extend life without regard to condition or the likelihood of recovery. So you don't see those very often, but that's certainly not out of the realm of legal possibilities. Okay, well, we've quickly examined 7 areas in which understanding and ethical decision-making is required. We looked at the definitions between legal and ethical elements. We addressed confidentiality and a patient and the role of the HIP Act. We looked at conflict of interest and an example of where conflict of interest came into play. We looked at patient discrimination and how that might raise its head. We defined fraud and checked out a good example of fraud, one that might sneak up on you. Also looked at informed consent and how that works out and what the respiratory therapist's role would be in that. And we've finished up here with an overview of informed consent and advanced directives. So I believe I'll just pass this back to the moderator, Bill, if you're there. And
I am here, John.
Take some questions.
Okay, I would really like to thank you for that terrific overview of the very common ethical principles that are out there that our practitioners deal with every day. And I think you've laid a very nice foundation for our next webcast, which is going to go into more specific examples of situations in which therapists are encountered commonly. We have not had any questions raised during your presentation, so you must have been pretty clear in what you were trying to say. But this is an opportunity for those of you that have questions to please submit them as we're wrapping up the program. And we will give that just a minute or two as you go through. Okay. Here we go. It says, I had a situation where I was present at the scene of an accident after work, and one of 3 victims needed moderate emergency care. The ambulance arrived shortly after and asked the loved one of the injured individual where they would like to go, to a small local hospital or a nearby trauma center where he's employed. After being asked this question, the family member looked at me and said, "What do you think? Where should we send him? Is this a conflict of interest for this person to recommend that they go to the facility where they're employed?" What's your comment on that, John?
Okay. That's interesting. I don't really think it is, because especially if you are acting in a patient's best interest, it's I believe if you wanted to stay on the safe side, I would just recuse yourself from it, and just maybe mention I would just have the patient go to the place where you believe they would receive the best emergent care. That's probably the safest ground to be on.
Yeah, and I think that if you would lay out just quickly the advantages of one over the other, and then mention and in closing mention the fact that you are employed at the one, that might even make it a little bit better.
Yes, that would just by default would recuse you. You could acknowledge that you do work at one, and say, well, I'm only familiar with care there because that's where I'm employed, and I can pretty well tell you that that's where I would go. But that would be basically excluding any conflict, I believe.
And thank you for that great question, Joel. Any other questions out there, please bring them forth now, and we'd be happy to address them. Well, seeing none, again, John, I want to thank you for your excellent presentation today. Wait a second. Okay, there's one more here?
Mm-hmm.
Yeah. Would you address that one, John? It says, would it be a conflict for me to tell a family member not to seek medical treatment from a doctor that I know to have poor skill?
Oh, that's an interesting one too. I think that I would, if I had concerns about that physician, I would do what you would do, and I would advise my family member not to use that physician, or better yet, I would recommend a physician I know to be competent, and say, if you're open to advice from me, I would suggest that you use this physician. I happen to know that this is the person I would use if I were in a similar circumstance. I think that's a little softer than just saying, well, don't use this physician. I think you'll be on good ground that way, and also in that you're inside. It's within your family. It's not like it's someone in the hall that you don't know or whatever. You're dealing with advising a family member, so I believe you have a right to render that opinion.
Okay, well, we are getting to the end of our hour, and for those of you that are watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your live CRCE contact hour. If you're watching this program as an archive, this concludes our presentation.